All right, guys. So today we're going to talk about angina or chest pain and some of the anti-anginal agents that we can use to prevent and or treat chest pain. All right, before we talk about the way that we treat angina, we need to talk a little bit about why it occurs. So angina occurs typically because of coronary artery disease or ischemic heart disease. Real quick, think about what ischemia is. Ischemia is when a tissue is not getting enough oxygen. In this case, the tissue that we're talking about is the heart. So the myocardium itself, right, the heart muscle itself, is not getting enough oxygen delivered to it via the coronary arteries. One of the reasons that this ischemia can occur and the chest pain can occur is because of atherosclerotic lesions building up in the coronary arteries. If you think about it, like here's a blood vessel and blood is flowing through the lumen of that vessel. When somebody has atherosclerotic lesions, which this happens when someone has really high cholesterol, that high cholesterol starts to build up and you end up with these lesions on the vessel walls. So when somebody has these atherosclerotic lesions, that decreases the lumen, right, of the blood vessel. That decreases the size of the blood vessel. So now not as much blood is able to be delivered through those coronary arteries. So if the myocardium is not getting enough blood, it's not getting enough oxygen. So there's going to be an imbalance between the oxygen demand and oxygen supply. That imbalance results in ischemia and pain, chest pain. So this presents in kind of a few different formats. This can present as stable angina, which is most common, or it can present as an acute coronary syndrome. So an acute coronary syndrome could be unstable angina, or the other acute coronary syndrome that we'll typically see is a myocardial infarction, an MI. A myocardial infarction, an MI, has or may have some of the same unstable angina symptoms. So unstable angina and a MI are both acute coronary syndrome. They're acute activities that are happening in the heart, and they have similar symptoms. But myocardial damage is present with a myocardial infarction. So you've blocked blood flow to part of the heart, and this blockage is so severe that you're actually causing cell death, right? You're causing necrosis in part of the heart. Because of that cell death, when the cells die, they burst and they release the components that were inside them, right? So as those cells are necrosing and dying, they're dumping their contents into the blood, and we can test for that. We can look at someone's blood and look for what we call biomarkers to see, hey, is there cell death in this person's heart? Is there actual damage in their heart, or are they just experiencing pain from, not enough blood flow? We would look for things like troponin, right? You see, is there troponin present? Or creatine kinase. If we see troponin or creatine kinase, elevated, that tells us this is not just unstable angina. This is not just chest pain. There's an actual MI occurring. There's actual cell death occurring in this person's heart. Also, so this is chest pain we're talking about, or this angina, is, we said, caused by atherosclerotic lesions, right? Narrowing the coronary arteries, making it harder to deliver blood. Or if there's a clot that gets blocked in that would cause an MI. Vascular spasms can also induce angina. This is not as common. We will talk about it a little bit, but it is possible for a vascular spasm, right, to squeeze the coronary arteries and block blood flow to part of the heart, causing chest pain. Again, that's not nearly as common. Symptoms of angina, angina pectoris to be specific, chest pain. It's characterized by a sudden, severe, crushing chest pain. Sometimes this pain will radiate to the neck or jaw, to the back or down the arms, most commonly the left arm, but that pain can radiate down the arms. Typically, though, we're seeing a sudden and severe chest pain. When somebody has coronary artery disease and angina, patients need to receive guideline-directed therapy that emphasizes lifestyle changes, management of risk factors, and then we also have, medications that we'll talk about. So as far as lifestyle changes go, smoking cessation, exercise, and weight reduction are key, because these are all things, smoking, a sedentary lifestyle, obesity, these are all things that can kind of worsen atherosclerosis and worsen coronary artery disease. So we recommend these lifestyle changes. We also have to kind of look at what else is going on in that patient's life, in other disease processes, and manage those risk factors. Other risk factors for coronary artery disease and angina include uncontrolled hypertension, uncontrolled diabetes, and dyslipidemia. So we've got to get their blood pressure under control, make sure their blood sugar is where it needs to be, and get their cholesterol and triglycerides down where they need to be. Finally, there are various medications that we can give to patients, one, on a daily basis to prevent the angina from occurring. Two, we have acute relief medications that we can give to patients if they do have an episode of angina. The medications that we'll talk about today include beta blockers, calcium channel blockers, nitrates like nitroglycerine or isosorbide, dinitrate, and then also sodium channel blockers like ranolazine. So there are three different patterns of angina, three different patterns of chest pain. There's unstable angina, there's stable angina, and then there's Prinzmetal angina, also called rest angina. So stable angina is also referred to as effort-induced. So that should kind of give you an idea that it's caused by increased effort. It's also referred to as classic angina because it's most common, right? So stable angina is the most common form of angina pectoris. With stable angina, the pattern of chest pain and the amount of effort needed to cause that chest pain does not vary over time. So you could say it's very predictable. The patient might be able to walk around their house, from room to room, okay, but if they try and go up a flight of stairs, they get chest pain, right? Every time. They know that that's their limit. Walking quickly up a flight of stairs, they can't do it. They'll get chest pain. Or maybe, they know that walking more than 20 yards is going to give them chest pain. Whatever it is, a certain amount of physical activity causes chest pain, and it's predictable. Every time it's the same, and it's also stopped. When they take nitroglycerin, it is relieved. I'll talk about that more in just a second. But they know what'll cause it, and they know how to relieve it. It is predictable, very stable. So stable angina is caused by a fixed obstruction in a coronary artery. That's just like what I just drew in that blood vessel with the atherosclerotic plaques. So if I have a coronary artery that's leading, bringing blood to part of my heart, and that coronary artery has an atherosclerotic plaque like this, that narrows the vessel, that amount. So the reason that this causes chest pain is that when the person's at rest, they're fine. At rest, this lumen size is enough for blood to get through. It's bringing enough oxygen to their heart. They're fine. There's not a problem. But this ischemic episode gets triggered by increased myocardial oxygen demand. So what this means is the person, their heart starts working harder, so it needs more blood flow. That's when they can't accomplish it. That's when the vessel can't give them more blood flow. It's already maxed out. So exercise. Exercise makes the heart beat harder and faster. If it's working harder, that means it needs more oxygen being delivered to it. You can't do that. Emotional stress or excitement. Well, that stuff triggers your sympathetic response. So the heart beats faster and harder, which means it's working harder. So you need to give it more blood. Can't do that. So anything that causes the cardiac workload to increase, it's going to make the heart crave more oxygen, right? It needs more blood flow, but this vessel can't give it more blood flow. It's blocked off. That is why there's an imbalance between oxygen supply and oxygen demand, right? Under normal resting circumstances, you can give the oxygen that the heart needs, right? But when the oxygen demand goes up, you can't, right? This person's not able to increase that supply to match. So there's an imbalance, and this causes chest pain. Now, symptoms of stable angina include a short-lasting burning, heaviness, squeezing in the chest, right? This kind of, really strong chest pain. It is possible for somebody to have atypical symptoms. Atypical symptoms include things like sweating, right? Diaphoresis, fatigue, nausea as well. Atypical presentation is more common in women. Also, diabetic patients and elderly patients, they're more likely to be atypical as well. So if you have a woman who's presenting with angina, she might tell you that she gets really nauseous and starts sweating, as opposed to that classic male presentation of chest pain. Something that is incredibly important with stable angina, when the person starts having chest pain, they're going to take nitroglycerin, or they're going to stop and rest, or both. This chest pain should be relieved by either of these. Remember, the problem was increased demand, right? And you couldn't increase the supply. So if the person rests, the demand will go down. That means that there should be a match again between supply and demand of oxygen, and the chest pain should go away. Also, again, all of our patients with angina, we're going to give them sublingual nitroglycerin for acute use. So if they're experiencing chest pain, they use the sublingual nitroglycerin. That should make the chest pain go away, typically within 5 minutes. I'll talk to you more about how we dose that in a little bit. So if the person has chest pain, they sit down and rest, they take their nitro and it does not go away, that is not stable angina, right? That is unstable angina. That's progressing, that's worsening, and that is dangerous. In that case, we would be worried that they were progressing to possibly a myocardial infarction. Unstable angina, which is not as common. Unstable angina is also referred to as increasing angina or crescendo angina. I don't know music, but I think crescendo is like when the music grows and bigger and bigger and bigger and bigger. It's like all the instruments are building up to like this big, I don't know. I think it's something like orchestra. You guys are probably laughing at me if you know anything about music. Sorry. Anyhow, unstable angina, crescendo, increasing angina. This is chest pain that increases in frequency or duration or is triggered by less and less effort. The point is that it is worsening, right? They're getting chest pain more and more and more frequently. Now, they used to be able to walk to the mailbox just fine. Now it's halfway there and they're having bad chest pain. Or the angina goes on for a really long time. Even after they rest, it's not going away. They take their nitro and it doesn't work. That is all indicative of unstable angina, which is dangerous. Suggestive of unstable angina, rest angina for more than 20 minutes. So the person sits down, they're at complete rest for 20 minutes or more, and it still hurts. New onset angina should always be checked out. So if the person has never had chest pain before and they get this crushing chest pain, they need to go to the hospital to have it checked out. Increasing angina, again, this is what I was just talking about, how it's getting worse and worse. Or if somebody has chest pain and then they also all of a sudden develop shortness of breath as well. Also, when we talk about unstable angina, again, the symptoms might not be relieved by nitroglycerin. So it's possible to have unstable angina and have the nitro still work, right? But say that the angina, you can do less and less and less activity, right? And, instead of taking 1 nitroglycerin, now it takes 3 doses. Like, that's still unstable angina. That's still worsening. But if you get to the point to where the symptoms are not relieved by nitroglycerin, this is very dangerous because that means that it's more likely that this is going to progress to a myocardial infarction. Which, remember, at that point, that means the heart is so starved for oxygen that it's dying, right? The cells are dying. So if nitro's not working, that is a medical emergency because it's more likely that that's going to progress to an MI and possible death. If unstable angina is present, the patient needs to be hospitalized and evaluated because they need more aggressive therapy. They need their angina to be treated more intensely on a chronic basis, and they need to be evaluated to make sure that they're not having an MI. So their blood needs to be tested for troponins. Prinzmetal angina, also called variant angina or vasospastic angina or rest angina, is uncommon. This is not a typical type of angina, but it is possible. The reason we call it rest angina is because this is not related to physical activity. Like, the problem here is not that you increased demand for oxygen. That's not the issue. What actually happens with this is, like it sounds, vasospastic. There's a vasospasm. The vessel, for whatever reason, goes spastic and contracts. So it's blocking blood flow or decreasing blood flow to the myocardium. So in this case, it's not that demand went up, instead supply went down. Not related to physical activity. It happens at rest. Treatment for Prinzmetal angina this generally responds promptly. It responds well to vasodilators like nitroglycerin. So when it happens, someone takes nitroglycerin, that works right away. And then calcium channel blockers for chronic therapy generally are very effective. One thing that's important to keep in mind is, when we talk about treating angina, we can talk about decreasing the demand, right? Like making sure that the heart doesn't beat too much. If we're talking about decreasing demand, that would not do us good here. In this case, demand is not a problem, right? In this case, the problem is the vessel. So you need a drug that works by dilating the vessel, right? That's something that's important to keep in mind here for rest angina. You can't just automatically treat it the exact same way as you would treat other types of angina. Okay, so here we see treatment strategies for how we treat angina. So medications are given to balance the oxygen supply and the oxygen demand. There are 4 general classes that are given if angina symptoms are present. And keep in mind here, like I'm talking about our, normal, stable angina, because that's what's most common. Again, also, all patients should make lifestyle modifications. All patients should have other risk factors like hypertension controlled. So first off, sublingual nitroglycerin is given to patients in order to treat an acute attack, right? So if somebody is having an acute attack of chest pain, they're going to take the sublingual nitroglycerin. It comes in little tablets as well as a spray. But they put it under their tongue, they let it dissolve, and that's for an acute attack. The beta blocker, which is what we would normally start with, like down here, this beta blocker is what we typically start with for chronic therapy, right? So this is the chronic drug. It's taken daily to decrease the number and intensity of attacks, right? So this sublingual nitroglycerin, this is immediate for an acute attack. I'll talk to you in a little bit about how you dose it and how you take it and some of the precautions, right? So the patient needs to have nitro just in case. The other meds down here are chronic medications that are given to decrease the number of attacks, right? To try and make it so that you don't actually get to that point. So a beta blocker is what we typically will give first. You give the beta blocker, you're going to titrate it to the maximum tolerated dose. If that is not effective, after titration, if it's not good enough, then you can add either a calcium channel blocker or you can add a long-acting nitrate. Long-acting nitrate is something like isosorbide dinitrate or isosorbide mononitrate, right? Those are long-acting as opposed to the sublingual nitroglycerin, which is quick. If you don't get adequate relief, then you can add. Notice each of these, you guys, is add. We're not taking away, we're not trading, we're adding. Then you can add the ranolazine. Ranolazine is a sodium channel blocker. It decreases intracellular sodium and calcium to decrease smooth muscle contraction. So smooth muscle is the muscle that's in the walls of your vessels, right? So decreasing smooth muscle contraction would cause dilation of the vessels. It isn't used much, and it's only in patients who've tried everything else. You've added everything else on, maximized doses, and they're still having angina. It works less in women. We don't see great efficacy in women. It has a ton of drug interactions. It prolongs the QT interval, which makes patients or puts patients at a greater risk for having arrhythmias. So there are problems with it, right? So we don't go to it first. That's like a last resort thing. So here you guys can see the drugs that tend to kind of kill 2 birds with 1 stone, or drugs that you can use for angina that are also good at treating other diseases that the patient might have. So here you can see a recent MI patients who've had a recent MI, once they've been stabilized, patients should be on beta blockers. So that's good. Long-acting nitrates are also good. So this kind of lets you know if your patient just had a recent MI, if you do the beta blocker and you're going to add something else, you know how it's a calcium channel blocker or a long-acting nitrate, go with the long-acting nitrate. If your patient has asthma or COPD, you might have a problem with the beta blocker. It kind of depends on the patient, how well controlled that patient is. And then, you could try a selective beta blocker, but that could also be problematic. So you might want to start with a calcium channel blocker or start with a long-acting nitrate and see if that will work for you, because that's not going to cause problems with the COPD or asthma like a beta blocker could. Because remember, in asthma, we use beta agonists, right, to cause bronchodilation. So a beta blocker could cause bronchoconstriction. Again, there are selective beta blockers where you're not as worried about that, but nothing is 100% selective. So the other agents might be preferable. You guys can kind of read through the rest of this. Same thing like diabetes, beta blockers can be problematic in diabetic patients. And they can block, especially type 1 diabetics, because they block the signs of hypoglycemia, most of the signs of hypoglycemia, so that can be problematic. But you guys can look through the rest of this. In general, everybody gets nitroglycerin. You start patients with a beta blocker. If that's not working, then you can add a long-acting nitro or a calcium channel blocker. That's typically where most patients are going to end up. So we'll talk through the major classes of meds that we use and kind of mention how they work and some little caveats. So we'll start with beta blockers. You guys should know what beta blockers are. These, remember, all end in olol. So metoprolol, atenolol, bisoprolol. Hopefully you recognize those from previous lectures. Beta blockers are recommended as initial anti-anginal therapy unless contraindicated, right? And they work by reducing oxygen demand. So beta blockers, remember, lower heart rate and they lower contractility, right? So the heart's not beating as fast and it's not beating as hard, which means it's not working as hard, so it doesn't need as much oxygen. Lowering demand allows the patient to be able to keep up with that oxygen demand. Again, recommended as initial therapy unless contraindicated. One thing that's important to keep in mind here, we are talking about traditional stable angina. We are not talking about rest angina. We do not use beta blockers in vasospastic angina. Remember, vasospastic angina, demand is not the problem. The problem is that the vessel is squeezing. So what we want to do there is relax the vessel. This could actually worsen symptoms because now the heart's not pumping as much blood. So you're actually decreasing blood flow in that case. So not in rest angina. We're talking about normal, stable angina. These work, they end up decreasing the frequency of angina attacks and decreasing the severity of angina attacks. Over time, we see that they also improve exercise tolerance, which is really important because we recommend that patients get exercise, they get physical activity, but physical activity causes angina. So it's a difficult balance there, but over time, as they take the beta blockers, their tolerance for exercise does improve. So again, we give these to all patients initially unless contraindicated. So let's talk about when would a beta blocker be contraindicated? Severe bradycardia, these lower heart rate. So if your patient has severe bradycardia, you cannot give a beta blocker. Patients with diabetes, peripheral vascular disease, and asthma, they're not necessarily contraindicated, but they have to be, they have to be monitored closely. And two, you can only use the cardioselective agents, right? So again, that's patients with diabetes, peripheral vascular disease, and asthma. Right? As I mentioned earlier, only cardioselective agents. So the selective beta blockers like metoprolol or atenolol, right? Those are recommended agents, and you have to keep close track of your patient. No, like pindolol or agents that have any intrinsic sympathomimetic activity. Okay. So again, atenolol, metoprolol, great choices if you, well, for any patient really, but especially if they have like asthma or diabetes. One thing that is important with beta blockers, you cannot stop a beta blocker abruptly. This is for any patient taking a beta blocker. You can't just stop it. So if the patient decides after a while they don't want to take it, or if you are going to change it or whatever, it has to be tapered gradually over 2 to 3 weeks, right? So taper slowly over 2 to 3 weeks to avoid severe rebound hypertension, rebound angina, or possible MI, right? So taper slowly over a couple weeks. And beta blockers are helpful in patients who have other cardiac issues as well. Beta blockers reduce the risk of MI and death in patients who've had a prior MI. You have to wait till they're stable to start it, but once they've been stabilized, you start them on a beta blocker, and it improves long-term health. They also improve morbidity and mortality in patients with heart failure. So those are a couple, other conditions that you could be killing 2 birds with 1 stone. Okay, so calcium channel blockers. You guys know that calcium channel blockers come in kind of different kinds, right? We have dihydropyridine calcium channel blockers, and then we have non-dihydropyridine calcium channel blockers. So in general, calcium channel blockers decrease vascular resistance, right? They cause vessels to dilate, so they decrease vascular resistance, which decreases afterload. If afterload, what that just means here, like this is your heart, your left ventricle pumps blood out through the aorta, right? If the aorta is squeezed tight, there's a big afterload, right? That means there's like a big pressure here in the vessel. So the more constricted the vessels are, the bigger the afterload, right? That's like the load after the aortic valve. So the left ventricle has to create enough force to push open that valve and push the blood out into the aorta. If there's a lot of resistance in the vessels, it's hard to push against that. The heart has to work hard. But if you have a drug that causes the vessels to relax, that decreases vascular resistance and it decreases afterload. So now, these vessels have less pressure. It's easier for the heart to push that valve open and push the blood out, right? So that decreases the workload of the heart. The heart doesn't have to work as hard, so it doesn't need as much oxygen, right? So that decreases oxygen demand because blood's easier to pump out. This also causes, dilation of vessels. If you relax coronary arteries, the arteries are bigger, so they accept more blood from the aorta. So more blood actually gets delivered to the heart itself. Finally, decreasing heart rate and contractility. This is the non-DHPs. So verapamil and diltiazem have effects in the heart. So they decrease heart rate, they decrease contractility. So these would be decreasing, oxygen demand. So kind of looking at the different ones. First off, the dihydropyridine calcium channel blockers, like amlodipine. Amlodipine works mostly on vessels, right? That's kind of the difference between DHPs and non-DHPs. Amlodipine works mostly on vessels. So it's going to cause vasodilation. This is going to, bring more blood supply to the heart. The non-DHPs like verapamil and diltiazem. Verapamil mainly affects the heart, right? Verapamil mainly affects the myocardium. So it decreases heart rate and contractility to decrease oxygen demand. Diltiazem kind of does both. Diltiazem decreases heart rate and causes vasodilation. It's like in the middle of the two. So if you kind of had to rate them, verapamil mainly affects the heart. Amlodipine mainly affects blood vessels. Diltiazem is in the middle. So that's something you need to keep in mind when you think about what type of angina you're treating, right? If you're treating just normal, stable angina, you could use any of them. But if you were treating rest angina, right? If you were treating like Prinzmetal rest angina, verapamil would not be effective because verapamil is only working at the heart. It's not working on the vessels. Like the other agents would work though. A couple things to keep in mind, just in general, we avoid short-acting nifedipine, okay? So nifedipine is a DHP calcium channel blocker. You could use nifedipine ER. You can use extended release nifedipine, but not short-acting. It's associated with bad outcomes. Or you could use amlodipine, right? Also, verapamil is, which works mostly at the heart, verapamil is contraindicated in AV conduction abnormalities and in heart failure. Okay, so verapamil, remember, is contraindicated in heart failure. Can't give it in heart failure. Same thing with diltiazem. Diltiazem, you can't give in heart failure, right? So both of the non-dihydropyridine calcium channel blockers, you can't give in heart failure. This is because of their negative inotropic effects. I'm not going to get into the discussion right now of why you can use beta blockers. We recommend beta blockers, but we contraindicate the non-DHP calcium channel blockers. They're both negative inotropes, but they do it in completely different ways. When we go over heart failure, I'll talk about why that is. Okay, so we start with beta blockers. Atenolol or metoprolol ER are generally recommended. Those don't work in vasospastic though. If that's not good enough, then we give patients calcium channel blockers. You can do amlodipine or nifedipine ER. Those mainly work on vessels. They would work in vasospastic or normal stable angina. The verapamil and diltiazem are also effective options. They cannot be given if the person also has heart failure. Verapamil does not work for vasospastic though. Okay, then that brings us to nitrates. Nitrates relieve symptoms in stable angina, unstable angina, and variant or Prinzmetal rest angina. The way that they work is by increasing nitric oxide. Nitric oxide is a pretty potent vasodilator. It causes vascular smooth muscle relaxation. Um, so this is actually beneficial in a couple different ways. One, large veins dilate. This decreases preload, which reduces the work of the heart. Preload is like how much blood you put into the heart when it's at rest. And the idea with the heart is more in, more out. So when the heart's at rest, if you fill it with a lot of blood, it contracts to pump all of that, to pump a lot of blood. So it's working harder. So if the large veins dilate, right, then they're putting, more blood is left in the veins and less is getting crammed into the heart. So the heart's not having to work as hard to keep up with all of that blood that keeps getting put in it. The coronary arteries dilate. This increases oxygen supply to the heart. So kinetics. When we look at the nitrates, we have kind of nitrates in a couple different versions. There's the nitroglycerin. Nitroglycerin is like the quick acting. And then we also have longer acting. So first off, let's talk about the sublingual nitroglycerin. So sublingual nitroglycerin is what patients use for acute attacks. So we try and prevent them, but they're going to happen sometimes. Patient starts getting chest pain, they're going to grab their nitroglycerin, put a tablet under their tongue, and let it dissolve under their tongue. Sublingual nitroglycerin has an onset of between 1 and 3 minutes. So the onset for sublingual nitroglycerin can be as quick as 1 minute. For the isosorbide, like mononitrate, it's about 30 minutes. So we don't use that, the isosorbide mononitrate or dinitrate, for acute attacks. We only use the sublingual nitroglycerin for the acute attack. Again, all patients should have sublingual nitroglycerin on hand for acute attacks. It comes in a sublingual tablet or a sublingual spray. The thing with nitroglycerin is it has significant first pass metabolism. So if they swallow that nitroglycerin, the liver is going to inactivate it before it gets into the blood, and it's going to take way longer before it works. So that doesn't work. They need to know that even the little pill they put under their tongue and let dissolve, and it'll enter into the bloodstream of the oral mucosa. Generally, what we tell patients with sublingual nitroglycerin is you take 1 tablet every 5 minutes for up to 3 doses as needed for chest pain. So you have chest pain, you put 1 tablet under your tongue and let it dissolve, right? Within a few minutes, it should start to work. If your chest pain goes away, that's fine. You don't have to take any more. You go about your day. If after 5 minutes you still have chest pain, call 911 and then take another. Within 5 minutes, if you still have chest pain, take another. So you can take up to 3 doses. But if that first dose does not work, they need to be calling 911. Because if that first dose didn't work, there's an increased likelihood that this is not just angina and that this might progress to an MI, in which case they need to be in the hospital immediately to get it taken care of. Okay, and they should have their nitro with them everywhere. If you're going anywhere you're going, nitro should be in your pocket with you. Okay, this down here is just showing you like the way that they work. I'm not super worried about it, just nitrates, increased nitric oxide. This ends up increasing cyclic GNP. But overall, the point is that increasing nitric oxide causes vascular muscle, like smooth muscle relaxation, which vasodilates the vessels. Long-acting nitrates, so isosorbide dinitrate and isosorbide mononitrate. Those work for like 12-hour periods of time, but they take 30 minutes to start working. So those are not used for acute situations. The isosorbides, those are, as we saw, added on to beta blocker therapy and they're taken chronically to decrease the number of attacks that people have. I'll talk to you guys in a second about the dosing scheme for the long-acting nitrates because it's actually pretty interesting. First off, adverse drug effects of nitrates. Headache is the most common. We know that headaches have something to do with blood flow changes in the brain. So like dilation followed by constriction, or constriction followed by dilation. These like big blood vessel changes, blood flow changes in the brain cause headaches. So something that causes vasodilation can cause a headache. Postural hypotension, flushing, and tachycardia. Postural hypotension is like, so when you stand up, like the typical response, right, is when you stand up, all your blood wants to rush down because of gravity, but your veins constrict, right? Your veins squeeze, and that pushes the blood up to keep your blood moving. Well, nitrates cause the veins to relax, so they prevent that response. So when you stand up, all the blood rushes down and stays down. And so you don't have blood flow to the brain, and you get dizzy and can, possibly pass out. So patients need to know to change, like to stand up, or if they're laying down, they're going to get up in the morning. Don't just get up and pop out of bed. It needs to be a slow progression. So first, sit up kind of slowly. Then, put your legs over the side of the bed. Slowly stand up. Like it's got to be a slow progression to give your body time to like accommodate those changes. Flushing. Flushing is because of vasodilation, right? Vasodilation brings blood up to the surface, and that can cause a flushing response. Tachycardia. Tachycardia, this is like a reflex tachycardia. When blood pressure goes down, the heart can respond by increasing heart rate to try and respond to that. These though, these typically just occur at high doses. Like you don't usually see these with sublingual nitro. If a patient's taking a kind of lower end dose, you don't usually see any of these. These are more high doses. One thing is nitro, the long-acting nitro does come in a patch. You do need to be careful when applying a patch. So if the patient's wife puts the patches on for the patient, she needs to be careful not to be touching the side of the pad with the medicine because it gets absorbed through the skin. So she might get a response from it if she doesn't need the drug. So it's going to cause increased maybe fainting or whatever. So you just have to be careful when putting the patches on someone else to make sure you're not touching the part where their medicine is. This is important. Nitrates are contraindicated when patients are taking PDE5 inhibitors, like sildenafil. Sildenafil is the drug name for Viagra. The reason for this is, so like for erectile dysfunction, sildenafil and other PDE5 inhibitors, these drugs that are used for erectile dysfunction, they also cause vasodilation. That's how they work. They just happen to work a lot at the vessels that are going to the penis. So they open up the vessels going to the penis, they increase blood flow, and that causes an erection. But they also cause some dilation in other areas. So we have a drug that causes dilation combined with another drug that causes dilation, and patients can get severe hypotension, which can be very dangerous. And this can be very problematic, especially if the patient's not taking the long-acting nitro and they just have the nitroglycerin as needed, because maybe they only take it once a month, right? Well, the sildenafil is just taken as needed too. So in the patient's eyes, they might tell you, I'm not going to take them both together, right? Like if I take the sildenafil, I won't take the nitro. If I take the nitro, I won't take the sildenafil. But the problem with this thought process is that, remember, chest pain is caused by increased physical activity. So the patient takes the Viagra, right, to maintain an erection, and then they have sex. That's increased physical activity. Like while they're having sex, they have a massively increased chance of having angina, which means they'll need to take the nitro. And at that point, it's not a choice anymore. Like you've already taken the sildenafil and you need to take the nitro. So what do, right? It's problematic. You can't just say, oh, I'll never take them together, I promise. It doesn't work that way. So this can be problematic because the other choices that we have for erectile dysfunction are not great. They involve things like urethral suppositories or injections into the penis, and nobody wants to do either of those. So it's a really difficult conversation with patients sometimes. Lastly, tolerance develops rapidly when nitrates are taken around the clock. So they cannot be taken around the clock, right? Patients, when you give them like isosorbide dinitrate or isosorbide mononitrate or the patch or whatever, they don't take it 24/7. There's a daily off period. There's a time in the day where the patient doesn't take the drug to prevent that tolerance from developing. So typically they go, 10 to 12 hours at night without the drug. So the patient will take it first thing in the morning, right? The isosorbide dinitrate. They get up in the morning and they take it. Within a half an hour, it starts working, works throughout the day. At night, within like 12 hours, it's worn off. At night, they don't take it. But at night, they're resting. So they don't have that increased demand on their heart, so it's fine. And then in the morning, they take it again. So it's like 12 on, 12 off. One thing to note, guys, for variant angina, like the Prinzmetal angina that's caused by vasospasms, nitrates work good for those patients. It's rare, but for those rare patients that exist, nitrates work good. But the off period for variant angina is in the afternoon. The reason for this is, for whatever reason, the vasospasms tend to be worst in the morning. So you don't want the off period to happen like first thing in the morning. So instead, if the patient takes it at bedtime, it lasts through that like 8 hours of night, and then they're covered for like 4 hours in the morning. And then, they'll be off of it for whatever, from like 11 until 11 or 10 until 10. And then they'll take it again. Just FYI. For stable angina, though, it's what we just mentioned. You take it in the morning, your off is at night. Nitro patches are used for stable angina, and you just apply one patch per day, but you just leave it on for 12 hours. So apply the patch in the morning, you leave it on for 12 hours, and then you take it off at night. So 12 on, 12 off, if it's the patch. All right, guys, that is it. Angina is pretty simple. Don't forget all of the drug interactions for calcium channel blockers and beta blockers, all of the adverse drug effects for beta blockers and calcium channel blockers, all of that information that you already learned still applies, right? The adverse drug effects don't disappear. It's just, I'm not going to tell you them every single time I mention a drug, okay? Just kind of giving you the new information. Alrighty, guys, thanks for watching. I hope that was helpful. There is a practice test on my Patreon page for pharmacology. The practice test is on the first cardiovascular unit. It has all of my clinical based questions for hypertension, for angina, and then for diuretics. And I will record the diuretic video next. All right, thanks guys, have a good one.